So for one of my clinical rotations, I was able to follow a PA in an after-hours pediatric urgent care clinic, and the most common things that we dealt with was either otitis media or otitis externa. Commonly referred to as swimmer's ear, otitis externa is basically cellulitis of the external ear canal. Things that increase your risk for developing otitis externa are vigorously cleaning your ear with things like a Q-tip, or the accumulation of moisture as what happens during and after swimming, or even from wearing things like earplugs or earphones. The vast majority, or about 90% of cases, have a bacterial cause. The most common organisms found are Pseudomonas and staph. Recurrent otitis externa could also be caused by a fungus, so keep that in mind. Patients typically complain of ear pain and auricle pain developing within 48 hours or less. The pain is often accompanied by a feeling of fullness or itchiness, and other symptoms may include things like drainage or hearing loss in the affected ear. A classic finding is pain when palpating or repositioning the auricle or tragus. The external ear canal may be erythematous or edematous. It may even get to the point where the ear canal is actually completely obstructed. Now, management of otitis externa includes the use of NSAIDs for pain and swelling. Topical anesthetics such as benzocaine are not typically used nowadays. Now, depending on disease severity, like the presence of fever or the extent of cellulitis, or whether the tympanic membrane is intact or not, this may change or affect how we treat. In the more mild cases, it may be appropriate to just prescribe something like an antiseptic and glucocorticoid, such as acetic acid and hydrocortisone drops. This is done with 5 drops 3 to 4 times daily for 7 days. However, I would like to mention that we never did this once in my clinical rotations. In moderate to more severe cases, without fever or ruptured tympanic membranes, fluoroquinolones such as ofloxacin or ciprofloxacin are usually the medications of choice, as they are effective against both Staphylococcus and Pseudomonas. These are administered 3 drops twice daily for 7 days in kids and in adults. Now, in those with a non-intact tympanic membrane, we will specifically use ciprofloxacin and possibly, in addition to that, dexamethasone, as other preparations like aminoglycosides or those with alcohol in their preparations can have an ototoxic effect. Now, for those that require systemic treatment due to symptoms like fever or extensive cellulitis, they may require oral antibiotics like levofloxacin or cefuroxime if they have a fluoroquinolone allergy. And ear drainage cultures should be obtained prior to therapy. I thought it also important to note that especially in the pediatric population, ear canals may be too obstructed to even get any eardrops down to where they need to be, and so an earwick may need to be used in order to deliver the medications all the way through the entire external ear canal. And as always, if signs and symptoms are significantly worse than what was described here, or if symptoms don't respond at all to treatment, then we'll be referring them to either the ED or an otolaryngologist.